हाँ, बिकॉज अभी थोड़ा सा लाइट अंदर कम आ रही थी तो मेरे को लगा कि बाहर ही आ जाती हो।
नहीं, आई रिमेम्बर कमिंग टू योर ब्यूटीफुल हाउस.
इट्स एक्चुअली माय एक्सरसाइज टाइम, सो वो एक्सरसाइज कराता है जो हमारा इंस्ट्रक्टर
अच्छा.
आता है, तो आज आई एम
ओके.
जस्ट या
The technical team, it's 1 more minute to go. You can start the procedure for going live so that we can start sharp at
Yeah,
6.
there's only 1 minute left, Monica.
Yes, ma'am.
सबसे पहले चीफ गेस्ट और गेस्ट ऑफ ऑनर्स आके बैठ गए.
मैम वही होता है हमेशा.
और जो सबसे लास्ट गेस्ट ऑफ ऑनर है वो सबसे पहले बैठ गया. ओके.
Shivani, can we go live now, please?
It's 6 o'clock.
The tech team, please give us a countdown so that we can start, please. Yeah, thank you so much. Are we live? Can I start? A very warm
Yes, ma'am,
welcome.
we are live.
A very warm welcome to all the esteemed faculty members and delegates who have joined us today for the 241st episode of the Happy Learning Masterclass webinar series. We are happy that we have Bareilly, Bijnor, Bulandshahr, Firozabad, Jhansi, Prayagraj, and Sultanpur societies who have joined us today for an important webinar on the theme of obstetric injuries. This webinar is designed by none other than the program director, Dr. N.C. Patel, sir, and we'll be happy to coordinate on his behalf. Dr. Monica here, Dr. Monica Gupta, madam, Dr. Nivedita, Dr. Shatabdi De, and Dr. Deepika Lugane as coordinators for this program. We welcome everyone. Can we have the inauguration slide, please? We evoke the blessings of Lord Almighty before we start the webinar, please. The inauguration slide, please. There's no audio. The tech team.
Yes, yes, ma'am, I'm sharing. Great.
Yes. If there's an issue, please let us know. We can go ahead. It's okay.
Yes, ma'am.
We seek blessings from Lord Almighty to bless all of us, and we start this webinar by introduction of our program director, Dr. N.C. Patel, sir. Sir has been the vice president of FOXY. Sir is an important medical legal consultant pan-India. He is also the author of the FOXY Uniform Consent books. He has been the organizing secretary of AICOG, the chairperson of the Ethics and Medical Legal Committee also. Sir has also been the past president of IMA Ahmedabad as well as the Ahmedabad OBGYN Society, and he has worked since the last 23 years in the Northeast districts as free medical camps, including Jammu and Kashmir and the Northeast Asia under the Seva Bharati program. Sir, we welcome you and we wish you all the very best for the forthcoming elections for the presidential year 2026. Over to you for your welcome address.
Thank you, Monica, for kind words. It gives me immense pleasure to welcome you all to this 241 episode of Happy Learning Masterclass. And just mention all the society who have joined: Bareilly, Bijnor, Bulandshahr, Firozabad, Jhansi, Prayagraj, and Sultanpur. I welcome all of you. I welcome Dr. Jaideep Malhotra, madam. She has kindly consented to be chief guest and to bless us. In spite of her very busy schedule, she has consented to be chief guest. And I was lucky to work under her able leadership as a President Foxy. I was vice president to her team, and we were just like a family. And I have learned so many things from Dr. Jaideep. So welcome, Dr. Jaideep, for our webinar. I also welcome learned guest of honor, Dr. Ranjana Khanna madam from Prayagraj, Dr. Alka Sethi madam from Jhansi, and both have kindly consented to be guest of honor to bless the webinar. And to rest of the guest of, hello, is there any, should I continue?
Yes, sir.
Yes. And also I welcome Dr. Agarwal madam from Bareilly. She has also kindly consented to be guest of honor. I also welcome learned chairperson who are going to chair respective session: Dr. Vidya Chaudhary from Jhansi, Dr. Latika Agarwal from Bareilly, and Dr. Uma Jaiswal from Prayagraj. They are going to chair very interesting session to be taken by Dr. Sehla Jamal, and she is going to discuss about obstetric anal sphincter injury. I also welcome one more set of chairperson, Dr. Prerna Agarwal madam from Firozabad and Dr. Sanjaya Sharma from Jhansi. They are going to chair very interesting session to be delivered by Dr. Sashibala Ramurthy, and she is going to talk about urinary tract injuries. I also welcome one more set of chairperson, Dr. Subha Pandey madam from Prayagraj, Dr. Mudura Sharma from Bareilly, Dr. Gayatri Singh madam from Bareilly, and they are going to chair interesting session about rupture of uterus in unscarred uterus, and it is to be dealt with by Dr. Manju Verma madam from Prayagraj. I also welcome one more set of chairperson, Dr. Indu Singh madam from Bulandshahr, Dr. Anita Nath from Bareilly, and Dr. Bina Singh madam from Bijnor, and they are going to chair one more interesting session: legal issues in obstetric injury, and it will be dealt by me only. And all the president and secretary of joining society and all the delegates, welcome to this 241 episode of Happy Learning Masterclass. In era of COVID-19, when I started this series, my intention was to just meet Foxian friends on screen and to discuss focus topic, because at that time physical meetings were not possible. And I started with only 3-4 friends, and I am happy to announce now it is a more than 8,000 happy members of Happy Learning Masterclass web series just now. And we have still continued to be with you all to discuss focus topic, as we are going to discuss today obstetric injuries. And our ultimate goal was to be helpful to our Foxian friend to update their knowledge in their day-to-day practice and to check maternal mortality and morbidity, because Government of India and WHO has given us a target to check maternal mortality, it should be less than 67, and infant mortality should be less than 12. Of course, there are few states in southern India particularly, they are having maternal mortality near 30. But at the same time, there are the few states in Uttar Pradesh and in northern eastern area where maternal mortality was 200. Now it has come below 200, but still it is near 200, and it's a matter of worry. And if you go join hand on part of government, federation like FOXY, IMA, and particularly obstetrician friends who are working in very remote rural India, if you go join hand, then it is possible to check maternal mortality and target given to us to be less than 67. So with this intention, we had started this series to discuss focus topic, and we are still continuing. So welcoming you all without wasting much of your time. Thank you very much.
Thank you, sir. And we wish you all the very best for the forthcoming elections. We request all the societies to please complete the nomination formalities for sir. And now it is my proud privilege to introduce our chief guest for today, Dr. Jaydeep Malhotra, Madam. She is the Managing Director of ART Rainbow IVF at Agra, current President of the INSERT, the past Chairperson of the FOXY FIGO REI Committee. She's also the member of the Accountability Group of PMNCH at WHO, the past President of various organizations including Aspire, FOXY, ISAR, IMS, SA of Man, ISPAT. She's also the current editor-in-chief at SAFOG and SFOMS at journals and many more books, a part of the editorial board of the JMSN and the co-editor of more than 65 books. She is the regional director of the South Asian Yandonan School for Ultrasound, professor at the Dubrovnik International University at Croatia, the past secretary and vice chairman of ICOG. She is one of the few to receive the FIGO Distinguished Women Award, Lifetime Achievement Award by ISRF and ISAR, the Legends of Foxy Award in 2025, Aspire Distinguished Service Award, recipient of the Nepal Samman, the recipient of the Honorary FRCOG and FRCPI. She is also certified, credited with the first 3,000 babies of Nepal, the first IVF TISA twins of the Uttar Pradesh, India. She is a chief advisor to Maulana Azad Medical College at GMC Aligarh and SMS Medical College at Jaipur. She is the initiator of the Club 35 Plus, the Rotary Club of Agra Grace, Adbhut Matrutva Award at the Film Festival at Lucknow, and the iMoms app, which is the winner of the Atmanirbhar app WhatsApp challenge. We welcome you, ma'am, and it is a proud privilege to have you on this platform today for the Happy Learning webinar series. Over to you for your address.
Thank you so much, Monica, for a very, very generous introduction. I don't think I require that at all. Um, but thanks again for, introducing me. And thank you, MC Patel, for inviting me to be here on your Happy Learning webinar. It's really a pleasure to see how sustained, persistent hard work you have done through the years, not only, from COVID, but much, much before. It's really, really heartening to see. And that's the kind of a dedication and I would say commitment which we require from anyone who's going to go for the highest post of Foxy. The topic today, which you have chosen, is really remarkable because, of course, these obstetric injuries are much rarer today. And that's why it becomes even more important because training on how to deal with them or preventing them, especially, is one of the major, major things which our postgraduates need to really learn. And in my work for FIGO, I have seen all over the world, especially fistulas and all these injuries are very, very common, and FIGO is also doing a lot of these workshops where obstetric injuries are being dealt. And they are really important because it's not only, of course, mortality is much lesser in them, but the quality of life because of morbidity which is caused by these is really important for us to bring it down so that women have a quality of life. And of course, our postgraduates and members really basically train themselves on how to prevent, specially, and then in case if they really happen, then how to deal with it. So I think it's going to be a phenomenal webinar with all the key speakers. And the I also like to say hello to my guest of honors, Dr. Ranjana and Dr. Alka Sethi, both very, very good friends. And all the speakers and the chairpersons are very, very well known to me. And I know I can't take names of everyone, but it's a real pleasure to be with all of you. And all the best to you, MC, for all your endeavors. God bless you.
Thank you. Thank you, madam, for sparing time to bless me. You are always with me in any of my academic activity. And I just mentioned I was lucky enough to work under you in 2018 as a Vice President of Foxy.
Thank you. Thank you, ma'am, for your kind words. Now our guest of honor is Dr. Ranjana Khanna, ma'am. She was a Vice President Foxy in 2017, ICOG Governing Council member in 21-25, President Allahabad Menopause Society in 25 to 27, Vice President UP 2025 to 26, Executive Member National ISOPAP from 23 to 25, Founder President of ISOPAP Prayagraj from 21 to 25, President of Allahabad OBGY Society from 13 to 17, Organizing Chairperson for National Conferences, and she has organized many conferences, and she was a faculty at national international conferences and delivered the prestigious Dr. Prabha Malhotra oration in 2023. And she is the author of many chapters and articles in the books and general, co-convener of Foxy GCPR on epilepsy in pregnancy. She has received Foxy Achievers Award, Foxy Dhira Award, Foxy Dr. D.K. Tank Reproductive Healthcare Promotion Trophy, and Foxy Smriti Malyan Award 2 for Save the Girl Child. Over to you, madam, for your blessings.
Thank you so much, Monica. This introduction was very heartening. Good evening, friends. It gives me great pleasure to be the guest of honor, to be invited by Dr. MC Patel for this very prestigious and very, very thoughtful webinar on obstetric injuries, which we are facing on a day-to-day basis. So it was very heartening and a great pleasure to meet, though virtually, the chief guest, Dr. Jaideep Malhotra. And it's always a pleasure to listen to you, Jaideep. And you are a wonderful orator. So it always gives me pleasure to take the little snippets of your talk. And it is good to meet my junior from GSVM, Dr. Lata Agarwal. And she's married to my batchmate Keshav, and they're doing extremely well in Bareilly. So lovely to see you, Lata. And of course, my very dear friend, Dr. Alka Sethi from Jhansi, who is a dynamo, and she has been consistently working all the years. And in fact, Dr. Goyal also I've had the pleasure of meeting in Hapur. The topics are fantastic. And for the first speaker, Dr. Shehla Jamal, I would like to say that this is one person who dons many hats. She is an OBGYN consultant, she is a teacher, she is a good orator, and she is a shire, and she is a social activist. So it's great listening to you, Shehla. And as speakers, we also have our very learned ex-HOD MLN Medical College, Dr. Manju Verma, ma'am, from Prayagraj. Okay, I wanted to say one thing, though the name of our city has changed to Prayagraj, but our society remains Allahabad OBGYN Society, because we have been registered already under that, and we did not want to change it to Prayagraj OBGYN Society. So I just wanted to point this out, that we are still Allahabad OBGYN Society, though the name of the city is now Prayagraj. And Dr. Shashi Bala is one of the speakers. And of course, Dr. MC Patel. He is the Foxy presidential candidate for this year. And whenever we have any medical legal problems, he seems to be always there, very helpful. So thank you, Dr. MC Patel, for that, and wishing you all the best in your Foxy presidential candidature. And now I think we have very excellent chairpersons too in this webinar. So I think I would conclude by saying happy learning to one and all.
Thank you. Thank you, madam, for sparing time to bless us.
Thank you.
Thank you, ma'am, for your kind words. Our next guest of honor is Dr. Colonel J.K. Goel, sir. He is a senior consultant at Faridabad, ex-senior professor at Hapur, and he has received many awards. Commander-in-Chief Commandment for Distinguished Services in Army in OBGY 1991, Certificate of Appreciation for Valued Contribution to Academics, Research and Overall Development of Institute, SRMS Trust Bareilly, and Best Department Award for OBGY SRMS IMS Bareilly. He has got extensive administrative experience. He was HOD at the military hospitals. He was nominated as an expert in Board of Studies to Humon University, Principal and Chief Medical Superintendent, Vice Principal, Medical Superintendent, and he has given justice to every post he has held. He is a chairperson for the Grievance Committee, and he was a peer reviewer of Active Medical International, JEMDS, General of Medical Sciences, and he was the author of chapters in Endocrinal Evaluation of Male Fertility in Yearbook of Indian Fertility Society. He has got vast experience of 44 years. I think sir has not joined. So whenever he will join, we will take his briefings.
Yes,
Our next guest of honor is Lata Agarwal, ma'am. She is a professor and unit head of OBGY in Rohilkhand Medical College, Bareilly, and International University, Bareilly. And she has got more than 19 years of teaching experience as UG and PG teacher. She's interested in high-risk pregnancies and published many research articles in reputed national and international journal. And she has actively participated as a faculty in many national, international workshops, conference, and CME. And she has received Golden Icon Samman in Kanpur in 2024. Over to you, madam, for your words of blessing.
Thank you, Monica ji. And I would like to say, good evening to all the seniors, juniors, and everybody has been talking so much. And I think praising all of us too much, so that I would like to say very shortly that we should start the talk and give the speakers more time to speak. And thank you, Dr. MC Patel, for giving me the honor of being guest of honor in your webinar. Thank you all so much.
Thank you, madam. Thank you.
Thank you, madam, for your short and sweet comments. Our next guest of honor is Lata Sethi, madam. She is a consultant and ex-medical superintendent, Cantonment Hospital, Jhansi, and she has been the president of Jhansi Society from 25 to 26, UP State Coordinator Foxy for 26, founder NIGF member, founder member of ISOPAP, IMA president from 20 to 23, founder member of IMS.
Dr. Monica, everything is visible and I hardly have too much to my credit. I'm a Harpan Mora.
And madam, you have got so many gold medals. I was just looking for your gold medal. You have got 6 gold medals in the MBBS. And now the gold rate has increased tremendously.
That is why I've stopped buying gold. Anyway, at the outset, good evening, everyone. Thank you, Dr. MC Patel, for inviting me as a guest of honor and under the chairmanship of Dr. Jaideep Malhotra, who is an icon herself. In fact, she was the one who installed me as a secretary in 2012. So I can never forget those days when they came to Jhansi for the first time. And after that, we've had the honor of having them in UPCOG also in 2012. We are really very, you're our guide, our mentor, and we are really happy to work under you. And we follow all your inspiration, instructions. Thank you, madam. Hats off to you. Now, Dr. Patel, what to say about Dr. Patel? Anything in medical legal, the name comes as Dr. Patel. And we had the honor of having him twice in Jhansi also. He came all the way from Gujarat to just bless us and to increase the awareness of medical legal aspect in medical science, in medicine at least, the importance. So, and he was our guide. He guided us so well that any problem any of us have, we call Dr. Patel. So we are really proud to have you, and I wish you all the best for your presidential candidature. God bless you. Everything has been said about the speakers, the chairpersons, but one special mention for my dearest Dr. Ranjana. We've had the honor of her also, and I cannot forget the evening when we were together when she came for CME. We had a real lovely time. I really cherish those moments. Now, without taking much time, topic is of course the need of the hour to reduce maternal mortality and morbidity. It's a very important topic, especially for the area of Bundelkhand, which is very backward, and home deliveries is very common. So it is one should be well versed with all these things so that we can spread the message to the villagers, to the junior doctors, to the ASHA workers, so that they're well aware and they can tackle, and early referral is there. Now, without taking much time, I hand over the mic to the MOC. Thank you very much for having me here once again. Thank you.
Thank you, madam, for sparing time for us. You are always with me in any of my academic activity. And I still remember you are good host when I visited Jhansi. It was nice time with you also. Thank you, madam.
Thank you, sir. Before concluding the inauguration ceremony, I just request everyone who has not nominated for MC Patel, sir, please nominate as a president candidate. The last date is 30th. Don't wait for 30th. Do it as soon as possible. And sir, with your permission, should we start with the academic program?
Yes.
Over to you, Deepika, for the academic program.
So thank you so much, Dr. Monica, and good evening to all our esteemed faculty. And thank you at the outset, Dr. MC Patel and Dr. Monica Omardan, for giving me this opportunity. And now we move on to the scientific session, and we welcome you to the 241st edition. And we now begin with our first scientific session, which is focusing on the topic obstetric, anal, and sphincter injury. It is my privilege to introduce our esteemed chairpersons for this session. Our first chairperson is Dr. Vidya Chaudhary, ma'am. Ma'am is the secretary of Jhansi Obs and Gynae Society. Ma'am is widely appreciated for her dedication to women's healthcare and her active involvement in academic and organizational activities in the field of obstetrics and gynecology. So we welcome you, ma'am. Our next chairperson is Dr. Latika Agarwal, ma'am, ma'am is the president of Bareilly Obs and Gynae Society. Madam is also the director of Atul Latika Hospital and Sarthak IVF Center, and has been faculty at multiple national conferences. Ma'am is the recipient of numerous awards and is highly respected for her contribution to infertility care and women's health services. So we are honored to have you, ma'am. Welcome, ma'am. Our third chairperson for the session is Dr. Uma Jaiswal, ma'am. Ma'am is the past secretary of the Prayagraj Obs and Gynae Society. She is the director of Shakuntala Hospital and head of Department of Obs and Gynae there. And she has served as the honorary secretary of Allahabad Obs and Gynae Society for 23-24 and also a Foxy Manyata trainer. Ma'am is widely admired for her commitment to academics, training, and quality maternal health care. We welcome you, ma'am. And could I request one of our chairpersons to please introduce our speaker for the session, Dr. Sheila Jamal, ma'am, who will be speaking on the topic of anal sphincter injuries. Dr. Uma, ma'am, can you
unmute yourself?
Unmute, ma'am.
Dr. Uma, please unmute.
Yeah, she's unmuted. Yes, ma'am.
Good evening, respected seniors and dear friends. Thank you, MC Patel sir and Dr. Monica for inviting me in Happy Learning Masterclass 241 series. And best wishes for upcoming election, Dr. M.D. Patel sir. Today we are going to have very important topic, that is obstetric anal injuries, that gives the hell of female's life if it happens. So for this, we are having very young and budding gynecologist and obstetrician in amongst ourselves, Dr. Shaila Jamal. She is hardcore menstrual health specialist and cosmetic gynecologist. She is unit head, Sarvodaya Hospital, Greater Noida, ex-professor Rashri Medical Research Institute, Bareilly, ex-assistant professor, Sharda University, Greater Noida. She has had many posts, and founder and president of Society of Menstrual Disorder and Hygiene Management. She is co-chairperson, Fetal Medicine and Genetic Committee, UPCOG. She is founder joint secretary, Greater Noida of St. Gynae Society. She is clinical secretary, West UP, ISOPA. She is member of Foxy ISAR, SFM, SMLM, ISOPA. She has many awards to her credits from post-graduation, University Gold Medal to Pradham Shri Kamalbai Hospital Award, SN Malhotra Award, Shailaja and Pandit Award, Foxy National Award. She is editor of Journal of Reproductive and Menstrual Health Sciences. She has published more than 40 papers and research in national and international journals, authorized around more than 15 chapters in many reputed journals, teacher at Dignity platform, own educational, she is having her own educational app, Dr. Shaila Class. Her specialization in natural PCOS reversal, natural fertility enhancement, and natural birth. She is giving a very, she is speaking in very good topic. And now the stage is yours, Dr. Shaila. Welcome you and overcome to you.
So
Dr.
thank you, ma'am.
Sneha.
Dr. Shella, please, the stage is yours, Dr. Shella. Please start.
Thank you so much, Uma ma'am, for those lovely words. Uh, I'll start sharing my screen.
Yes, ma'am.
Deepika ma'am, please let me know whether my screen is visible or not.
Yes, we can see. Dr. Shella, dikh raha hai.
ठीक है. Thank you so much and good evening to all my respected seniors. And I would like to thank MC Patel sir for giving me this opportunity to talk on a very important topic, as has been highlighted by all the esteemed chairpersons today. And sir, this is a future manifestation of you being Foxy president. And please give me an opportunity to host a podcast with you. So best wishes to you, sir. So I would like to start with one labor room scene that as obstetrician we all would like to avoid. Getting a call from labor delivery suite and juniors or we ourselves are seeing that all is not well. We remember this very famous scene from movie Three Idiots where Amir Khan conducted a delivery which was vacuum assisted delivery so called. It went on so smoothly. I wish all instrumental and assisted vaginal deliveries went off that well. When we look at ancient literature, it has been imperatively said by Hippocrates himself that there is a difference between vaginal delivery and a normal delivery. Birth through vaginal canal, which is not ensuring integrity of birth canal, which is leading to excessive bleeding or neonatal depression or trauma, can never be a normal delivery. It is just a vaginal delivery conducted nicely, not so nicely, or badly. Lessons from the past: when we look, early obstetric lacerations were known in ancient Indian literature as well. For severe tears sustained during childbirth, strict bed rest, prolonged fasting was recommended. Even well into medieval and later times, surgical repair was often delayed for months to allow inflammation and infection to subside before attempting any crude stitching. In Hippocratic method for repair of fistulae that arise out of obstetric injuries, in around 400 BC onwards, he treated fistulas by threading materials like horsehair through the tract and tightening it periodically. And while I was surfing through such kind of literature, mention of application of cautery material, application of hot tongs, just in order to get the fistula repaired, mention of application of cow dung and what not has been there, but in vain, as it was never a strategy to treat those obstetric injuries. So why we are talking of obstetric anal sphincter injuries? Because as we all know that incidence has a bit decreased, but a third degree or fourth degree tears is still occurring in about 3 in 100 women having a vaginal birth. And it is more common so with first vaginal birth, but is not so uncommon in a multiparate too. Where are we as long as the literature and reported incidence is concerned? Obstetric anal sphincter injuries, which involve grade 3 and 4 perineal tears during vaginal delivery, affect an estimated of 0.4% to 2.1% of vaginal births in India. And let us all remember that this is the reported incidence. Vaginal deliveries conducted at home or not by the qualified practitioners can be still higher. These injuries significantly impair women's quality of life, often leading to immediate postpartum pain, long-term consequences like fistula, fecal incontinence, or dyspareunia. Trends when we see, on one hand, we are saying that incidence of OSC has decreased. But when we look at the masters of the world in obstetrics, that is England, they report an increasing trend. In fact, not only doubling, but tripling from 1.8% to 5.9% in the recent times, that is from 2000 to 2012. And the overall incidence reported in UK is 2.9%, which ranges up to 8% even. An incidence of 6.1% in primipary as compared to 1.7% in multipary. So why so? Maybe because there are increased institutional deliveries, because there is increased identification and increased awareness and training of the obstetricians and midwives over there. More so, there is another perspective to this rate of increase, that is having an advanced maternal age at the time of first birth itself, more hyperglycemic pregnancies leading to large for gestational age feti, and higher maternal BMI, which is an important risk factor for sustaining obstetric anal sphincter injuries. So what's and what's of obstetric anal sphincter injuries? We know we are talking of the tears which range from third degree to fourth degree. So third degree tear is classified further into A, B, and C. When A occurs, it is involving external anal sphincter, and less than 50% of the thickness of external anal sphincter is involved. In 3B, more than or equal to 50% of external anal sphincter thickness is involved. In 3C, both external as well as internal anal sphincters are involved. And in fourth degree, it is 3C combined with rectal mucosa. And if there is any doubt during examination about the degree of third degree tear, it is advisable to classify it to the higher degree rather than on lower degree, so as to give the maximum and optimal repair in that session itself. There is one sister classification to this, which is obstetric rectal buttonhole tear. And if the tear is involving the rectal mucosa with an intact anal sphincter complex, it is not a fourth degree tear. Rather, it has to be documented as obstetric rectal buttonhole tear. And if it is not recognized and repaired, this type of tear may lead and will lead to a rectovaginal fistula formation. Risk factor when we talk Asian ethnicity, nulliparity, birth weight greater than 4 kg, shoulder dystocia, malpresentation, prolonged second stage, and instrumental deliveries are important risk factors. But recent Journal of Clinical Epidemiology has mentioned that in addition to all these, birthing positions, precipitate labor, and oligohydramnios may also be very important reasons for sustaining birth trauma. So while we are conducting deliveries in such situations, we should be much, much aware and vigilant from the examination and repair point of view. When we talk of India, forget about Asian ethnicity. Being Indian is a risk factor to develop anal sphincter injury during vaginal deliveries. So we have very, very different set of data with us. In different presentations and publications, we have found that most cases of perineal tears, which are documented in Indian scenarios, have no obvious risk factors. So if we are looking for particular risk factors and then only being vigilant during a vaginal birth, we might be missing out to so many things, so many kind of sphincter injuries. So we have to be vigilant in 100% of the deliveries, so as nothing is missed for repair, and nothing is left for chance and for future presentations. Now, how to identify? This is most important part of the presentation. Visual assessment of the extent of perineal trauma to include structures involved, the apex of injury, and assessment of bleeding. Rectal examination is very important to assess whether there has been any damage to external or internal sphincter. And the practice says that we do a digital rectal examination, ask the patient to tighten her anal sphincter and notice the tone. Internal anal sphincter will not have that great a tone, especially immediately after birth and sustaining a trauma. So that has to be visually inspected all the times. Lithotomy position has to be there to allow adequate visual assessment, and systematic assessment and its results should be fully documented and preferably pictorially, especially if you have identified one. Role of endoanal USG, because of the latest advancements in techniques, AI, and biofeedback AI backed up systems. Do we find it very important? And is it important to have a one ultrasound machine, especially equipped with endoanal probe? So during studies, it was found that when we use this endoanal ultrasound modality, there we are able to identify occult injuries, and we can identify them up to the tune of 33% of women. But when this ultrasound was performed immediately following delivery, the detection rate of OSS was not significantly increased compared with clinical examination alone. So the take home is digital rectal examination is imperative and should never be missed. So once identified, immediate repair is the rule by a trained clinician with consent and full explanation to the lady and family as well. So how do we repair? It should take place in an operating theater under regional or general anesthesia with good lighting and appropriate instruments. But we don't forget that we sometimes miss this important step, and a repair is taken place in labor room itself, which also is not wrong. RCOG also endorses this practice that whenever it is not available or not possible, then it can be conducted in labor delivery room itself, provided there is adequate analgesia as well as lighting facility. Second important point during repair is figure of 8 sutures should never be taken during the repair of OSs because they are hemostatic in nature and may cause tissue ischemia. And preferred is regional, or if mother is very uncooperative, then general anesthesia may also be given. Good light, as I mentioned earlier also. If patient is bleeding, a vaginal pack may be inserted so that we can visualize the apex and the structures nicely. Now we start from 4th degree. So 4th degree meaning by involvement of 3rd degree perineal tear along with mucosa of the rectum. So we see here that continuous or interrupted suturing fashion can be applied. So it depends on the surgeon's choice whether she wants to do it in a continuous or an interrupted manner. There is no rule to it. Second is we have to use 3-0 vicryl suture, and we are not using PDL suture as it is causing a lot of tissue irritation, and previously it was professed a lot. Nowadays we have switched to 3-0 vicryl completely. It causes better healing, causes less irritation. That's why it is preferred. When we move on to the next lesser grade, that is 3C, which means involvement of external anal sphincter as well as internal anal sphincter. We have to see if the torn internal anal sphincter can be identified. It is advisable to repair this separately with interrupted or mattress sutures without any attempt to overlap internal anal sphincter. So I was again searching through the literature, and mattress sutures were recommended in lesser frequency. It is the interrupted manner in which internal anal sphincter should be taken. Studies have also demonstrated that a separate repair of internal anal sphincter improves the likelihood of subsequent anal incontinence and continence. Here we switch to Vicryl 2.0, or even PDS can be used. So, but we prefer using Vicryl 2.0. As I was going through the literature in the entire Indian subcontinent, Vicryl 2.0 is the preferred suture material. Now, burying of surgical knots beneath the superficial perineal muscles is recommended to minimize the risk of knot and suture migration to the skin, and I'm sure we all are doing that. Moving on to lesser degree, that is external sphincter 50% or less than 50% or more than 50%. If it is a full thickness external anal sphincter tear, we can utilize either an overlapping or an end-to-end approximation methods with equivalent outcomes. So there is no debate over here what is the best. Both are equal. So surgeon comfortable with end-to-end anastomosis or an overlapping technique, both are giving equivalent results. But for partial thickness, an end-to-end technique should be used, because when we are causing this overlapping technique in partial thickness repair, we are putting undue tension, which may later lead to breakdown, cause lot of irritation, and may lead to dehiscence later on during the course of repair. The overlap technique can only be used for full thickness tears to allow the torn ends to be overlapped without tension, and this technique has only been described to repair full thickness external anal sphincter tears. How to identify external ear sphincters? This is how we teach our students also, that when we look at the perineum, circular muscular layer is visualized, and it is almost a rule of the world that one end of external anal sphincter will go deep down into the muscular layer, and one end of external anal sphincter will be coming out, popping itself and showing itself to us that I'm here. So it is good idea to hold both the ends with Ellis forceps, and if it is a full thickness, we can go for either overlapping or end-to-end anastomosis. If it is partial, it is better to do it just a approximation method. So this is how end-to-end anastomosis is done, and this is how overlapping technique is used in full thickness external anal sphincter injuries. Use of antimicrobials. Broad spectrum antibiotic cover is recommended following this repair to reduce risk of post-op infections and dehiscence. And use of post-operative laxatives is also recommended to reduce the risk of wound dehiscence. But one thing is important: the aim of providing laxatives to the patient should not be to produce loose stools. Again, it will be a contaminating wound. The frequency of loose stools will be there. They will keep on dripping and keep on infecting the repaired wound. So softener, stool softeners should be provided, and the aim should be just to soften up the stool so that she's not straining hard on stools. Bulking agents should not be given routinely with laxatives. In fact, they should not be given with laxatives in any of the case. Perineal care, whatever the patient is comfortable with, and there is equal evidence regarding providing them with either ice packing or warm sitz bath. Both are equivalent, and it depends on the patient's preference. Pelvic floor muscle training with or without biofeedback may be instituted after 7 to 10 days of doing this primary repair. A bit about preventing obstetric anal sphincter injuries, and I'll talk about OAC care bundle, that is OAC-CB. There are 4 important components to this. First component being antenatal information for women. Second being episiotomy and how and when we should be giving that. Third is documented use of manual perineal protection. And fourth is perineum should be examined after every childbirth. So we'll discuss first bundle, that is antenatal discussion. So healthcare providers discuss the risk of OSC during pregnancy, providing expectant mothers with educational materials to help them make informed choices about labor, pushing and birthing positions. And it is recommended that this education should be provided to them from 32 weeks in antenatal period. And the personal risk factors and ways to minimize their risk, including 3 subsequent components of the care bundles, should be informed to the lady. And they should be provided a discussion guide to highlight women's active participation. And this particular discussion guide is available online, and it was developed with women's feedback to support this component. Second bundle is manual perineal protection during the second stage of labor. When the woman is actively pushing, the midwife or doctor manually supports the perineum while simultaneously controlling the speed of baby's crowning head. For spontaneous vaginal birth, manual perineal protection should be used unless the woman's chosen birth position, suppose water birth or she's standing and squatting, and it is not enabling a provider to give manual perineal protection. For assisted vaginal births like forceps or ventouse, MPP should always be used unless the woman declines this technique. So controlled delivery and MPP, the left hand is slowing down the delivery of head, right hand is protecting the perineum, mother is not pushing when the head is crowning, and this should be imperatively communicated to the lady. And think about episiotomy, especially in higher risk group, and deciding a correct angle of instituting this episiotomy. Ridgen maneuver, which has been classically followed since ages, that is delivering the fetal head using one hand to pull the fetal chin from between the maternal anus and the coccyx, and the other hand on the fetal occiput to control the speed of delivery, as shown in this picture. And this picture has been taken from William Obstetrics. So this was classically being followed, and it is documented to reduce obstetric anal sphincter injuries by utilizing this method. Now modified Ridgen maneuvers are also there, but I think classic Ridgen maneuvers does the job wonderfully. Third bundle is applying mediolateral episiotomy. When it is clinically required, why it is clinically required? It's mentioned because routine institution of mediolateral or median episiotomy is discouraged. So it's an obstetrician's jurisdiction. It lies under them, their judgment area, whether the episiotomy is required or not. So basically, it is required to make space for the baby. It is performed at a specific angle, ideally at 60 degrees from the midline, to prevent the cut from tearing further down into the anal sphincter. So when we talk of this angle, if we see, the angle should be 60 degree at the time of crowning, not before or after that. Second point is the incision should be around 4 centimeter long and around 1 to 3 centimeter from midline, depending on the stage of labor. So ideally, it should be around 3 centimeter from midline to make it a 60-degree angle mediolateral episiotomy. So when a huge study was conducted to assess the competency of even the senior obstetricians to institute mediolateral episiotomy at correct angle, all were shocked because only 22% of the doctors were putting it at the correct angle. Because if episiotomy is given at, say, 45 degrees, it results in post-delivery angle of 20 degree, where the risk of sustaining a trauma is around 80%. So a good training is required even for a simple and most commonly performed obstetric intervention, that is episiotomy. And it should never be given before crowning unless there is a specified reason, which we don't think so, like it is existing. It should preferably be given in a single cut and not multiple cuts should be made, because it then definitely is going to extend in its course. So there is one innovation. This is known as epi scissors. So if we look at epi scissors, it is technically designed to protect midline and put a episiotomy incision, periotomy incision at 60 degrees, which later on results in a post delivery angle of 43 degrees. So if available, I think this should be preferred. Now, fourth bundle, that is systematic postnatal examination. A thorough examination of the perineum, vagina, anal sphincter is performed to identify any tears that may have occurred so that they can be accurately repaired at that particular time. And it should be done even if perineum appears intact. Even after repair of episiotomy, however confident we are, a digital rectal examination should never be missed. So, a word about obstetric anal sphincter injury care bundle 2. It is a cluster randomized hybrid evaluation of strategies for sustainable implementation of OAC care bundle in maternity units in Great Britain. I think it has been there since 2023 or 24. The project is still ongoing. Good results are coming, and they may come out with obstetric anal sphincter injury care bundle set of 2, but 4 sets that I have discussed will be there, and they are working on them only. Other methods of preventing anal sphincter injuries are warm compresses, like applying a warm, moist cloth to the perineum during the second stage of labor. And second is antenatal and intrapartum massage, which is like stretching the perineal tissues with massage from 34 weeks of pregnancy. It is to be conducted and continued till the onset of labor, and especially done during the second stage of labor because it is thought that it can increase tissue elasticity. Moreover, a woman becomes very, very aware and mindful of her labor process. And it is because of this process that her tissues are relaxed and she is able to cooperate more. So, how to do a perineal massage? We educate patient to gently insert her thumbs or 1 to 2 fingers into the posterior vaginal wall. She is then gently pushing it downwards towards the anal side, and then she is spreading those either fingers or thumbs to the sides of the vagina. This is to be done for around 2 to 3 minutes and 2 to 3 times a week till the onset of labor. And in fact, some studies are coming that women who are doing perineal massage have more chances of passing into spontaneous labor, and this is what we all wish for. Two more important things that I would like to discuss here is few gray areas. Like people nowadays are promoting natural birth without minimum aid, with minimum interference by the birth attendant and a doctor and an obstetrician. So in that course, one important thing which is coming out, and India is having 2 excellent water birth units. So having a water birth, is that increasing the risk of obstetric anal sphincter injuries? The answer is yes. Second concern is doula practice. When we talk of respectful maternal care, we talk of birth companion. So, birth companion here becomes all the more important because directly it may not be preventing, but the confidence that the lady gains, the care she receives, massaging can help a lot in preventing, like in gaining her cooperation during the second stage of labor. And maybe we are preventing a bit of OAC in this manner also. Birth positions like squatting and leaning forward while standing may increase, though not statistically significant, but yes, they are more amenable to put a woman at risk of developing injuries. Then, if a lady has sustained obstetric anal sphincter injury in the index pregnancy, what about her future delivery plans? The literature says counsel her for elective cesarean birth, but on a case to case basis, if the baby is small, her otherwise her pelvis is good, there is no risk factor as we have discussed, then she can go for a vaginal delivery. And in that case, role of prophylactic episiotomy is still controversial, but rates of dehiscence, a perineum being very rigid, is very common. So it is seen that routinely in such cases, episiotomy has to be given, and they do extend also. So this has to be discussed with the lady before she goes in for any kind of choice. So now, if we are not identifying them, properly repairing them, then we are putting a woman at risk of fecal incontinence, flatus incontinence, dyspareunia, and maybe aperiunia, because day before yesterday only one lady came with fourth degree perineal tear, and she came with secondary pseudo infertility because she had no sexual intercourse since the delivery of her last baby. She belongs to nearby vicinity only, and a home delivery was conducted. So, in order to prevent such things, we have to be more vigilant. She may report vulvodynia, socio-psychological stress and issues, and such kind of scenarios that is still not very uncommon. We see 4th-degree perineal tears, ORBTs also. And if I have to rate one surgery which is the most beautiful vaginal surgery, it is repair of old complete perineal tear. There is no satisfaction in the world comparable to seeing a woman's perineum being restored, she gaining confidence and thanking you. So, if we see such things, although this is out of the scope for today's discussion, it should be revised after 6 to 12 weeks. And need for colorectal surgeon on case to case basis, because there are sometimes higher extents into anorectal mucosa. So, H-shaped incision, butterfly incision, bowel preparation should be done. Antibiotics should be given, laxatives should be given, perineal care should be done. And to just conclude, as Shahrukh Khan always says, कि कोई भी काम छोटा नहीं होता, तो इसमें हर चीज की importance है to prevent obstetric anal sphincter injuries. So first is we have to follow OAC care bundle. Manual perineal protection and controlled head delivery should be educated to all. And I think art of birthing, like a conclave which recently happened also, these should be conducted. Like people should be taught how to beautifully conduct a vaginal delivery, an imperative perineal and rectal examination after each vaginal birth, training, and training. And seniors should also supervise how juniors are being trained so that they learn directly from the mentors. They don't have to look at YouTubes or certain unverified sources before they learn this art of repairing. And future delivery counseling should be done in a very good manner so that in future also we are able to avoid obstetric anal sphincter injuries. So that's all from my side. Thank you so much. Thank you so much to all for a patient listening.
Thank you, Dr. Snehal. That was really very informative, both about the preventive as well as the curative aspect. I would now request the chairpersons to give in their comments before we move to the next session.
It is a complete and very excellent talk. You have covered all the things together. First, prediction is very important, as you say, when patient came to us, because chances of anal sphincter injuries are very less in our setups. But when the identification of these injuries, when the patients came from the remote areas or peripheral areas, and proper repair, we have to do it. And when we are teaching our students or our staff और अपने junior doctors को जो teach करते हैं, proper technique of episiotomy and how we give, what are the indications properly, and if it happens with them at any center, how to identify and repair properly. Thank you so much.
Thank you, ma'am.
Complete talk. Randa ma'am, any comment?
Thank you.
डॉक्टर निवेदिता, आप तो बहुत रिमोट एरिया में काम करते हैं, आप अपने कमेंट दीजिए.
नहीं, मैं कोऑर्डिनेट कर रही हूँ अभी.
Very nice talk,
Yes, ma'am.
Dr. Stella.
Very
Seeing you
nice.
after such a long time.
Yeah.
Yes,
Thank you.
ma'am, requesting you to conduct the next session.
Yeah.
Yeah.
Thank you, Dr.
Thank you
Snehal.
so much.
Now we moving on to the second session. We move from posterior to anterior to cover the urinary tract injuries. And to chair this session, we have with us Dr. Prerna Agarwal. And I think the wrong slide is coming up. ये तो आपका ये वाला है. Dr. Prerna Agarwal, she is the president, Firozabad Obs and Gynae Society. And okay. She deals with infertility and high-risk pregnancies and received the North Zone Yuva Foxy Award in the 46th AICOG 2003. She's participated in faculty in both national and state level conferences, and she's also the founder secretary of Firozabad Obs and Gynae Society. The next chairperson for the same session is Dr. Sanjaya Sharma. She's the past president of Jhansi Obs and Gynae Society, and she's worked at the MLB Medical College Jhansi till 2026 and has worked as HOD and Dean of Academics, and she's been the president Jhansi Society till 2024 and has published many papers in various journals. I would request any of the chairpersons to please introduce the speaker for today, Dr. Shashibala Ramamurthy. Do we have any of the chairs with us? Then I'll go ahead. Dr. Shashibala is a senior consultant of.
I can introduce her, Dr. Nivedita.
Yeah. Dr. Mridula, good
evening.
From
Bareilly. Good evening. She's from Bareilly. She is the head of the department at Shri Ramamurthy Smarak Institute of Medical Sciences. And she's a very accomplished gynecologist and been in teaching. She's a professor in that college and has been teaching for more than 25 years. Shashi?
Yes, ma'am. Thank you, ma'am. Thank you so much, ma'am.
Yes. So, and she's a very active member of Bareilly Obs and Gynae Society. She has been regularly conducting lot of seminars and CMEs in SRMS and academic excellence at par. This formal introduction, I think we can do away with that, but she has lots of contribution in academics, many publications, awards to her name. And welcome, Dr. Shashi. It's always a pleasure to listen to you. It's a pleasure to listen to Dr. Shaila. And now another academician from Bareilly, Dr. Shashi. So over to you, Dr. Shashi.
Thank you, ma'am. Thank you, everyone, for giving me this opportunity in this conclave. So I'm sharing my slide. Is it visible to all of you? Am I audible, ma'am?
Yes, you're audible, and yeah, your slides have come up. Could you please make it full screen and then you're ready to go?
Okay. So should I start?
Yeah, definitely.
Okay. So after this oasis, I'm going to talk about the urinary tract injuries. Is it on slideshow, ma'am?
No, ma'am. It's not on slideshow. It's
Is it okay?
You make it full screen. Yeah. Now you are on full screen. Perfect.
Okay.
Perfect.
Thank you, ma'am. Thank you, Mridula, ma'am, for nice introduction, madam. Thank you so much. So urinary tract injury, urinary tract is including urethra, bladder, and ureter. And it is one of the most serious complications of a gynecological procedures with incidence varying 0.4 to 2.5 and about 75% of ureteric injuries occurring during abdominal gynecological procedures. Gynecological diseases can involve इसको बंद कर दीजिए कहाँ से Sorry, ma'am. Can I take 1 minute? My slides are visible, madam?
Yes, Dr. Shashi, they are all visible, very clear.
But I'm not able to see my slides somehow.
Maybe they are hidden from your end.
Yes, ma'am. Maybe. Yes, now they are there on the screen. So the common surgical procedure leading to ureteric injuries are many, but for gynecological perspective, 75% of the injuries, they are resulting from gynecological operations. Can be easily missed, particularly when they are unilateral. Only 1/3 of the cases are diagnosed intraoperatively. Delay in diagnosis can lead to severe morbidity and even loss of renal function at times. Also, the most common cause of medical legal action against gynecologists. Ureter has basically 3 layers. We all know that it has adventitia, muscularis, and the mucosa. And if we go for the anatomy, first we have to recall the anatomy of the ureter. It has an abdominal part and as well as the pelvic part of the ureter and divided into abdominal and pelvic segments. each 12 to 15 centimeter in length. The abdominal part lies on the anterior surface of the psoas muscle and crosses over the iliac vessels to the pelvic inlet as shown in this image. So within the pelvis, that is most important part of the ureter we delve with. The ureter lies close to the iliac vessels. We all know that. Lies anterior to the psoas, cross over the iliac, right over external, left over the common iliac, crossing anteriorly by the gonadal vessels. So this is the anatomical aspects of the ureter. And there are certain areas where we as a gynecologist and obstetrician can damage the ureter. That is famously known as a water under the bridge, the tunnel of Verdheims, and the knee of the ureter. So these are the three most common reasons where we can injure the ureter. The important one is the knee of the ureter. The knee of the ureter makes where and it enters into the trigone. That is also very important. When we close the vagina after hysterectomy and the tissues are lax and we take a deep void at the angle, sometimes we may cause injury to the ureter. So ureteric injuries can occur because in abdominal operations, vaginal operations, or even in laparoscopy. Intraoperative injuries to the ureter may result from ligation, crushing, transecting, partial or complete angulation, ischemia, intentional resection, or there may be thermal injuries during laparoscopic or even in open benign or malignant procedures, gynecological procedures. The factors which are disposing these are large ovarian fibroid, ovarian masses, ovarian fibroid, uterine fibroid, endometriosis, pelvic inflammatory disease, frozen pelvis, previous pelvic surgeries, genital tuberculosis, malignancy cases, or certain congenital anomaly. During this dissection, we could see that in the iliac vessels, the ureter is lying here, and it is almost when we do the internal iliac ligation or lymphadenectomy for the malignant disorders, gynecological disorders, we may encounter the ureter. Today itself, I did one case today, that is vaginoplasty, and the patient was MRKS syndrome. So in these patients also, we did a laparoscopic vaginoplasty. One can see there is no uterus and the ureter is lying very vicinity of the vaginoplasty. So this is the small video showing the ureter, how close it is when we perform any surgery, even for benign gynecology. So the ureter is lying here. You could appreciate this ureter, and it is there, peristaltic movements you can see. So slightest of the thermal injury can lead to damage to the ureter, and which could later present as a uretrovaginal fistulas. So there are many other causes also, like fibroid. This is a lantern type of uterus, and the fibroid is sitting in the lowermost part of the uterus, and the uterus is sitting on the fibroid. They distort the anatomy, and if we are not vigilant enough, we can cause different kind of ureteric injuries. Similarly, the patients who are having this kind of fibroids, they can distort the anatomy, and sometimes ureter might be damaged. If we do not see for the lighthouse of the uterus, we have to see the landmarks, and then the surgical procedure is to be done. Similarly, though the submucosal fibroid, this is laparoscopically removed, but this does not. So how could we prevent? First is the preoperative prevention. We have to see whether we are dealing with the difficult cases. Every hysterectomy is not the same hysterectomy. Every cesarean section is not the same cesarean section. However, even the most skillful will injure the ureter inadvertently, but on rare occasion, if you respect the planes, if you respect the tissue, and if you respect the landmarks. So we all are senior obstetrician gynecologists, and this for students also, tracing the ureter before clamping, or knowing, even though but still we know where the ureter is going, that is more than enough. And if we are doing the surgery for the benign gynecological disorder, one should do the intrafacial technique of hysterectomy. That is most important to safeguard the urinary. Then different kind of vaginal surgeries, we can injure the urinary tract, including bladder, urethra, or even the ureter. So in even simple cases of hysterectomy for benign disorder, post cesarean section, these kind of anatomy we can find at times. And here you could not even see the ureter. And you can inadvertently injure the ureter either by the energy source or by the RF plasma or harmonic scan. Of cases, you can have different location of the ureter and even the bladder. One has to be very vigilant while we are dealing cases like in this picture. You are seeing the endometrioma, and the uterus is also stuck into the pouch of Douglas, and totally the picture is like a frozen pelvis. But sometimes you may get the chocolate cyst, difficult chocolate cyst, or sometimes you may get the easy chocolate cyst. So right one, this is easy chocolate cyst. There is hardly any risk of damaging the urinary tract. But on the left side, you could see in this type of endometriosis where all the sections are the where the all pelvis is frozen, and it is even have included the gut. So then the chances of even urinary tract injury is highest. So there are other preventive measures has been advocated, like stenting, different kind of illuminating stenting during laparoscopic surgeries. But still, the best anatomy, if you respect the anatomy, respect the tissue, respect the plane, then I don't think that we need to stent the ureter. Sometimes stenting of the ureter may distort so much that we can inadvertently injure the ureter. But still, the evidences say that we can do the stenting of the uterus. If the beginners are doing laparoscopy or surgeries, then they can go with the stenting. Lighted ureteric stent is one of the very popular in advanced laparoscopic surgeries where lots of dissection has to be done in the pelvis and lower abdomen. So how to diagnose? Obviously, the diagnosis is in the sixth sense. We could freeze at times during surgery that yes, we have damaged something, and that we have to respect. We cannot say, okay, we have not damaged anything. So prompt identification and gut feeling, it's very important. If you could have done something, then and there it has to be picked up. Otherwise, there are dye tests, and you can even do the intraoperative cystoscopy, and you can non-obstructed, partial obstructed, and late injuries can secondary to ischemia and avascular necrosis could not be diagnosed by cystoscopy. That is the pitfall of cystoscopy. Use of perioperative laparoscopic ultrasound probe. Focus is everywhere, in the labor room, in the wards, in the OTs, everywhere we are now having the facility of ultrasonography. So this picture is good. If you are good at ultrasound, you can even predict that you have injured or ligated the ureter. So the symptoms, they will come late. Loin pain, flank pain, post-operative rounds. If the patient is having fever, loin, flank pain, don't ignore. Or adynamic ileus. Fistulas will present later. There may be simple lower abdominal pelvic collection of urine. Urinoma may develop. Anuria will develop within 24 hours. If there is only one kidney, as I have shown in my image, my patient was having only one kidney. So if inadvertently, unluckily, if we ligate the another ureter, then of course the patient will develop anuria. Otherwise, in ureteric injuries or urinary tract injuries, anuria will not happen, but the patient may develop hematuria. So how to manage? Obviously, it is a urinary tract injuries should be dealt with a multidisciplinary approach. And there are guidelines. If the injury has happened, our aim is to detect and inform our team as well as to the patient. So for different type of injuries, there are different type of protocols mentioned in the literature. And for total resection, the type of injury, total resection, you have to do the ureteroneocystostomy. I have witnessed 2 cases, even mine cases, I have caused the ureteric injury, and I took the onus. Patient has come to me, and then again we did this with the urosurgeon. I put the ureter, the ureter was implanted in the bladder by neurosurgeon, and the patients were fine, and they are following up. They are 2014. In case of ureteric injury, an optional outcome results in accurately diagnosing the type of injury and its location, protecting the kidney, and finally by correcting the ureteral injury. Thermal injury, resection with management as per transaction. So now after ureter, we come over to the bladder. As madam has already narrated that OSS is there. Similarly, there are increased chances of cesarean. There are increased incidence of cesarean section nowadays. So day in and day out, we are seeing this type of picture. Previous to cesarean with placenta lying low, and there is a thin segment, scar rupture, scar dehiscence. In those kind of patients, there are chances of bladder injury. So genitourinary fistulas, they develop later when we inadvertently take a bite, or we can coagulate some part of the mucosa of the bladder, or we have deep sutures in the mucosa of the bladder. There may be fistula later develops, or you can even diagnose it intraoperatively also. So nowadays, cesarean section is also a big deal because we are operating upon previously scarred uterus. So there are many obstetric cause and many gynecological the development of urinary fistulas or the bladder injuries. Fistulas will develop later, and we could diagnose them later in post-operative period, while the bladder injury you can recognize then and there intraoperatively, and that is the best. And the outcome of bladder injury is also best when you detect, diagnose, and treat intraoperatively. So we all know the various causes of bladder injury, the urethral injury, bladder neck necrosis. There may be gynecological various causes, and there may be obstetric causes of urinary tract injury. Epidemiological wise, they are not very common, but they are not very rare also. And in Western world, they have even reduced it to some of the hospitals to the 0 level. There are tract injuries also. Oncological surgeon, they may encounter these kind of injuries because there is lots of dissection to be done while they are dealing with the ovarian, uterine, or cervical cancers. So how to diagnose the whether it is uretrovaginal fistula, vesicovaginal fistula, and erythrovaginal fistula? Since ages we are reading, learning, and doing these 3 swab tests, but nowadays we have good cystoscopy facility, good CT scans, so we can diagnose other way also. But yes, of course, though these 3 swab test is not very specific, but it has a sensitivity, yes, something is leaking. So this is the flow diagram, how to treat the patients of vesicovaginal fistula and how to go about it. So as I have already said, it is a multidisciplinary approach, and we have to take into consideration patient's wish also, and our neurosurgeon, surgeon, as well as the senior obstetrician has to be considered in these cases. So definitive surgery, if there is a fistula and we have diagnosis late, by that time there is a there is a less of the edema and the tissue strength will come. The other principle of surgery remains same. Of course, we have to do perfect asepsis, good exposure of the fistula, excision of the scar tissue, and mobilization of the bladder from vagina, and then we have to suture the bladder without any tension. Abdominal versus transvaginal repair, of course, the experts will tell or comment upon this. Criteria for successful repair, we must know that if the fistula is single and it is a only vesicovaginal fistula, the size is smaller. Fistulas have good prognosis. If the urethral involvement is not there, if you are doing the fistula repair for patients who have history of obstructed labor, then it is going to be a difficult task. If there is no vaginal and ureter are draining inside the bladder, not in the vagina, and circumferential defect is absent. So these are the good prognostic sign. We can counsel our patient if we know all these good in cases of urinary tract injury. So the venial sin is injury to the urinary tract, The moral sin is failure of recognition. That is most important. Thank you. Thank you very much. Thank you for the
Thank you, Dr.
patient hearing.
Shashibana. And requesting the chairpersons to give their inputs. And if the chairpersons are not there, Dr. Mridula, would you do the honors? Hello.
Hello. Yes, ma'am.
Yeah.
That was a wonderful talk, Dr. Shashi. You pointed
you,
out
ma'am.
all the precautions that we have to keep in mind when we are doing difficult surgeries. These injuries can occur in a very, seemingly a very easy surgery also. If we are not keeping a track on the anatomy, that can get altered. And as you have very rightly pointed out by giving various examples that how these injuries are possible and how to take care of them. Excellent deliberation. Congratulations.
Thank you, ma'am. Thank you so much. Thank you for giving me the opportunity.
I now hand over to the next coordinator,
Yes,
Dr.
ma'am.
Monica.
Yes, ma'am. Then can we have the introductory slides, please? The third session would be on ruptured uterus in an unscarred uterus. And speaker is none other than Dr. Manju Verma, madam. Our chairpersons for the session, Dr. Shubha Pandey, madam, Dr. Mridula Sharma, madam, and Dr. Gayatri Singh. Dr. Shubha Pandey, madam, is the head of the department at the Kamala Nehru Memorial Hospital at Prayagraj. She's also the deputy medical superintendent of the hospital and president of the Prayagraj OBGYN Society from 23 to 24. She has more than 40 years of experience and she is especially interested in infertility.
That's enough. Thank you.
Yeah, thank you, ma'am, for joining us today. Our next chairperson is Dr. Mridula, madam. She's the Department of OBGYN at Rajashri Medical Research Institute at Bareilly, Director of the Dharmadatta City Hospital, Chairperson of the UPCOG Oncology Committee, UP State Coordinator, immediate past President of the Bareilly OBGYN Society. We welcome you, ma'am.
Thank you, Dr. Monica.
Our next chairperson, Dr. Gayatri Madam, is the past secretary of the Bareilly OBGYN Society, member of the Public Awareness Committee, Oncology Committee, and she has been invited as a faculty in national and state conferences. We welcome you, ma'am, and we request you to please introduce our speaker.
Can I introduce her?
Sure, ma'am. Please go ahead.
Dr. Gayatri?
Dr.
Yes,
Manju Verma has been my teacher.
Sure, ma'am. Please go ahead, ma'am.
Listen.
Shubha, ma'am, please go ahead.
Dr. Manju Verma has been my teacher. So obviously I like introducing her. She's won the Certificate of Honor in Medicine. Dr. Shiv Narayan Gold Medal. Dr. Gold Medal.
Shubha, enough. Everybody knows.
Pranam, Manju, ma'am.
You are the best. Chal. She still keeps
की शुभकामनाएं मेरे लिए बहुत बड़ी चीज है.
Tell your doctor. Ready to listen to you?
Let me share my screen. क्या चाहिए? सेव कहाँ किया है? I must say thanks to Dr. Patel for including me into the very, very important session. And I would like to say, wish him all success, a thumping success in all the endeavors that she has, that he is going to have in the future. Hello?
Yes, ma'am, you're audible. We can hear you.
You are
we can hear
audible,
you.
ma'am.
Okay. So thank you, Dr. Patel, again, that you have included me in such a very special and interesting session.
with all the two speakers giving such insight into the subject of injuries. Now I'm going to the third type. That is the most dangerous and, even associated with mortality as far as it is concerned. In addition to the morbidity, the rupture of an unscarred uterus. Because scarred uterus, we all know we can get a preparation done beforehand. But with unscarred uterus, it comes as an emergency. So I would like to say that just coming on to what is a uterine rupture is, it is a catastrophic obstetric emergency, and it is associated with significant fetal-maternal morbidity and mortality. Now, it is very, very unfortunate, unusual, and a sudden thing that happens in obstetric complications. It is very uncommon, uterine rupture is an uncommon but life-threatening obstetrical complication with high mortality, has already been said so. And traditionally, unscarred, the primary gravida, are the women which are with unscarred uterus are considered immune to rupture. It was being said so. But rupture usually occurs during labor, and every second time, a second of a time is vital for the survival of the patient. Now, coming on to the definition, how it is to be defined is, it is a non-surgical disruption or a tear of the myometrium with or without serosa of the uterus being involved, with or without of expulsion of the fetus and the placenta into the peritoneal cavity. The unscarred uterine rupture can occur even without any unidentifiable etiological cause. Now, a rupture can be a complete rupture or an incomplete rupture, and we all know when all the three layers are being involved, with the fetus and the placenta being extruded into the peritoneal cavity or not, can be a complete rupture, or incomplete rupture can be when there is a peritoneal membrane is intact and we can see the amniotic sac, can be seen through it. The sites of rupture, unscarred rupture, are basically cornual, which can be even right or left, depending upon whether it is which type of a pregnancy it is. Then it can be a fundal rupture, it can be a low segment uterine rupture, or as in the lateral wall, rupture can also occur. Coming on to the epidemiology, there are a number of studies which have been said. Incidence ranges from 0.03 to 0.08. In India, JIPMER has quoted an incidence of 0.28%, and it has usually has occurred during labor in an unscarred uterus. The developing countries has a higher incidence, has been noted by JIPMER, that 33%, 14% in emergency, they were not being in the hospital while being delivered. So this is something very, very important, that the hospital delivery has got a lower incidence as compared to patients who are delivering at home or at a place where the facilities are not very up to the mark. The risk factors involved as far as the rupture of an unscarred uterus is basically the congenital uterine anomaly, amounting to approximately 1 in 200. The overall incidence being 0.28. According to the studies which have been already mentioned over here, minor uterine anomaly like arcuate uterus, separate uterus, and major uterine anomalies included uterine unicornate uterus, didelphus, bicornate uterus. A rudimentary horn can also rupture with the highest incidence of 81%, and hypoplastic uterus, a collagen disease like Ehlers-Danlos syndrome and LD syndrome. All these syndromes are being associated with high incidence of unscarred rupture uterus. Trauma during pregnancy can also result in rupture of a unscarred uterus. That is basically if this injury occurs in the third trimester, and can be associated with pelvic fractures, bladder injuries, and typically affecting the uterine fundus or uterine scar. It can be because of the hyperstimulation during labor because of induction or augmentation. The oxytocin induction and augmentation has resulted in various studies with an incidence of 43% as the highest, and the lowest has to be 4.34%. Cervical ripening with misoprostol or dinoprostone has also been contributing to the rupture of uterus. Maternal cocaine use also has been attributed as one of the factors, and obstructed labor due to cephalopelvic disproportion. I think this is the most common cause as far as the institutional deliveries are concerned. The risk factors again can be if the age is more than 30. The chances of rupture may be 1.1 to 1.4%. In a grand multipara, out of the 0.08, 31% can be more than 5 if the parity is there, or 32% if the parity is more than 4. Uterine distension with the embryo infusion or polyhydramnios or multiple pregnancy can also result in rupture of unscarred uterus. Similarly, if the fault can lie in the fetal macrosomia, and it has been said according to the weight, if the weight is more than or equal to 400 grams, the incidence can be as high as 2.6%. The gestational age, if it is more than 40, also is a contributory factor. During labor, dystocias, internal podalic version, breech extraction, shoulder dystocia, crissula manua, malpresentation are contributing factors. But besides that, there can be other things like manual removal of placenta or placenta accreta, pacreta, or can be cornual or angular pregnancy. Now, coming on to how will a patient present? So the typical presentation depends upon the site and the extent of the uterine defect. It can result sudden tearing, a sensation of sudden tearing in the abdominal, in the abdomen with a increase in with a pain in abdomen. Vaginal hemorrhage can be there. It can be hematuria. It can be associated with hematuria. Cessation of uterine contraction is the most common thing that occurs usually when there are uterus ruptures. Features of the shock may be there in the form of maternal tachycardia or hypotension. The internal abdominal hemorrhage can be estimated if there is a chest or a shoulder tip pain because of the peritoneal irritation that occurs. There can be shortness of breath. There can be palpable fetal parts when abdominal examination is done. There can be a suprapubic bulge, or there can be, if a vaginal examination is done, there can be a recession of the presenting part. The most important one is the abnormal fetal heart sound. The fetal bradycardia has been noted as to be the first sign in 87%, prolonged deceleration in 79%, fetal distress in 78%, and fetal bradycardia or prolonged deceleration in 80%. So if any of these signs are there, I think one should always keep uterine rupture in mind. Atypically, there can be incomplete rupture producing localized abdominal pain or tenderness. Frank signs of hemorrhage and shock develop slowly, and it may be confused with accidental hemorrhage. Coming on to the management, basically the golden rule is that the uterine rupture is a clinical diagnosis, and there must be a high index of suspicion by the health care provider. Uterine rupture should be first ruled out in all pregnant women presenting with acute abdominal pain, regardless of their gestational age. The investigation for coming to the diagnosis, they can be enumerated as CTG, because nowadays CTG is being put to every pregnant patient as for monitoring the progress of labor. And therefore, the fetal distress, if it occurs, it has already said, is the first sign that can be there as a presenting sign for rupture of uterus. There can be diminished baseline uterine pressure, and there may be loss of uterine contractility, which can easily be seen on the chart of CTG. The other investigation that can be done, the ultrasound, that I think is the best. MRI can be done, but it is not practical. The intrauterine pressure catheter can also be used to diagnose it. Now, coming on to the ultrasonography, this is probably the safest and the most useful imaging technique during pregnancy. Before rupture, a uterine wall thinner than 2 mm, as determined on USG, performed within 1 week of delivery, significantly increase the risk of uterine rupture. The positive and negative predictive value were 73.9% and 100% respectively, because the negative predictive value is much more important. Then our first study suggested that French study suggested that a uterine wall thickness of greater than 4.5 mm has negative predictive value of 100%. So this is how one can find out that the utility of ultrasonography as the diagnostic investigation. Once the rupture has occurred, now the ultrasonography will identification of protruding portion of the amniotic sac can be seen. There can be a myometrial defect which can be seen as an hypo or anechoic line. Then it can be a large empty uterus with gas bubble. There can be fetus and placenta in the abdominal cavity, or an extrauterine hematoma may be present, especially in the broad ligament. And hemiperitoneum or free fluid can also be detected on ultrasonography. MRI, of course, is something much more precise, but it takes a lot of time, and it is not something which is very, very particular, but it can delineate the rupture very, very clearly and 100%. Intrauterine pressure catheters not used nowadays because there is a loss of pressure. Then treatment of the threatening rupture. Now coming on to the etiology, the treatment, it is basically that if you are suspecting, somebody is suspecting a uterine rupture, the treatment of that is the therapy. The uterus is basically the immediate cesarean section. That is the golden rule as far as the management is concerned. Now, principles of treatment of uterine rupture include intensive resuscitation because there are a lot of intra-abdominal bleeding may be there, emergency laparotomy, broad-spectrum antibiotics, overall, and adequate post-operative care that has to be instituted so that the post-operative morbidity should not occur. The intensive resuscitation include correction of hypovolemia because caused by hemorrhage and dehydration. Intravenous broad spectrum antibiotics should be given. The monitoring to ensure adequate fluid and blood replacement is there, but there should not be, the volume expander should not be used because they will result in more DIs, the form of coagulation defects, and there are chances of more deterioration as far as the condition of the patient is concerned. So once all these things are being done, laparotomy should not be delayed once the patient condition has improved. Then coming on to the repair of a uterine repair, the possible is hysterectomy may be indicated if hemorrhage persists, either total or subtotal can be done. There is no harm, and evidence suggests regarding which type of thread, knotting or sequencing of the suturing is more favorable. Any type of thing can be done to reduce the risk of uterine rupture later on. In cases of lateral rupture involving lower uterine segment and uterine artery, where hemorrhage and hematoma obscure the operative field, ligation of the ipsilateral hypogastric artery should be done to stop the bleeding. The uterine repair has been achieved it is important to note that the repeat rupture occurs in approximately 20% of cases, and therefore a proper counseling should be done if one is going to repair the uterus. Then suppose a patient, now this is if a patient is already there, suppose a patient comes in emergency. So exploratory laparotomy is to be done with delivery. Then, there are certain rules which, if being followed, there are less chances of morbidity and mortality to the mother. And the fetus. The several studies have shown that the delivery of the fetus within 10 to 37 minutes of the uterine rupture, if it is done, then this is going to prevent serious fetal morbidity and mortality. So, which means that exploratory laparotomy and delivery of the fetus should be done as early as possible. The surgical treatment will depend upon the type of uterine rupture, the extent and the degree of uterine rupture, the amount of hemorrhage, parity of the patient, edges of the ruptures are ragged or irregular, general condition of the mother and mother's desire for future fertility. The surgical options which are available to a surgeon is hysterectomy. The treatment of choice, this is the treatment of choice. The total or subtotal, whichever is feasible at that time can be done. Rupture repair can be done. Repair with the sterilization can also be done. I think this, if repair is done, this should be, presented to the patient that there are likely chances of rupture again in the subsequent pregnancy, and therefore, unless this is very, very important, it's better to do a repair and do a sterilization. Sorry, it's not a sterilization, it is the tubal ligation that should be done. Conservative surgical management, as I already said, is only indicated if the patient is desirous of the future childbearing. Low transverse uterine rupture is there. No extension of the tear to the broad ligament, cervix, or the paracarpus is there. easily controllable uterine hemorrhage with good general condition and no clinical or laboratory evidence of coagulopathy. Now, coming on to the definitive surgical treatment, hysterectomy is considered to be the treatment of choice when intractable uterine bleeding occurs or when the uterine rupture sites are multiple, longitudinal or low-lying. The complications with the rupture uterus when it is being repaired can be a post-operative infection because the patient has already been in labor for a quite long time, and damage to the ureters or bladder can be there. The amniotic fluid embolism can occur because of the strong uterine contractions if it is there. Then massive maternal hemorrhage can also occur with disseminated intravascular coagulation. Because of the increased hemorrhage or PPH increased hemorrhage, there are chances of pituitary failure with Sheehan syndrome later on, and bladder rupture already said. So the neonatal complication can be hypoxia and anoxia occurring in 8%, acidosis with pH more than 7 in 33%, Apgar score less than 7 in 26% in one of the studies. Admission to NICU was found to be 43%, with perinatal deaths in 74% in developing countries. So this is very, very important whenever we are dealing with such a case of rupture uterus. The maternal consequences because of the severe loss. Cystostomy may be needed in 11%. Hysterectomy has been done in 21%, and deaths can occur in developed countries with much less, that is 0.32, with developing countries must be as high as 8%. The prognosis of a rupture scar is associated with death. 6.2% has been noted to be with the infant death, and in Dutch national study there was no pregnancy-related maternal deaths due to uterine rupture, but the perinatal death occurred in 8.7%. The outcome of this repair of uterine rupture can be death, which is not very uncommon, and 8% has been reported to be one of the incidences. Mortality appears to be higher in women who have an unscarred uterus than when the rupture occurs outside the hospital. The overall mortality being 15.9%, and perinatal morbidity rate associated with uterine rupture ranges from 8 to 56%. Then concluding the talk, the uterine rupture is a rare but often catastrophic obstetric complication with an overall incidence of 0.07% of pregnancies. Diagnosis is mostly clinical and it should be suspected clinically. It is better. Most require intensive resuscitation. Surgery is mostly definitive, that is hysterectomy, and indication and repair with or without tubal ligation to be done with definitive indications and proper counseling, as there are chances of a recurrence in 20%. So here I finish off. Thank you for the patient listening.
Gayatri, unmute.
Thank you, ma'am. Very nicely explained the untouched topic. And I'm privileged to chair your session. Such a great person, such a great teacher, mentor, and a person with golden heart. Ma'am, usually the term when the rupture of uterus confronts us, only and only risk factor comes into our mind is previous cesarean or myomectomy scar. But we should always keep in mind that rupture can occur in the absence of any risk factor also. So be alert whenever there is change in labor pattern, whenever there is sudden fetal bradycardia or loss of station of the head of the presenting part, and there is sudden deterioration of the patient's vitals. So always keep in mind that it can occur even in the absence of scars, previous scars. Thank you, ma'am.
Thank you, Vita.
That was one wonderful talk, ma'am. You are truly a teacher of teachers, ma'am, and it's always a pleasure to listen to you.
Brenda. Thank
So
you.
much to learn, so much to learn always, ma'am. And we would also like to thank Dr. MC Patel, sir, for including us in this wonderful platform of happy learning. And best wishes to sir for a great success in the upcoming Foxy elections also.
Yes.
It's really a pleasure listening to Manju madam. So that is why I was glued to the laptop. I said I must listen to your whole talk. So it was really very informative, wonderful. Thank you, madam. You're really teacher of teachers. Our
Thank
teacher also.
Madam is an academic in charge for many societies.
Yes, yes.
And it is not a very big thing for her. She is having a tips in tips everything. She is the master of everything.
She has
Obviously,
everything at her
gynae or
fingertips.
whatever subject you can ask for.
Madam simplifies the complex clinical situations and then makes it so easy for us to, learn it. And then it's kind of a practical learning for all of us.
Very true.
So
Thank you, everyone.
thank you so
Thank you,
much,
Manju.
ma'am. Thank
Thank
you.
you, ma'am. Thank you for
Thank you, Dr.
being
Patel,
with us.
again, and wish you success, thumping success again for
Thank
your
you.
endeavor.
Thank you. Thank you.
Thank you. Thank you, sir.
Thank you, Patel sir.
Yes, thank you.
It is really, really, to be, all the time I join the sessions, this happy learning, and it is really something which new comes out, and you see, you learn so many things. Thank you very much, Dr. Patel.
Thank you. Thank you, ma'am.
Should we move ahead, sir?
Yes.
Yes. A very good evening to everyone. We have had those 3 very nice lectures. Now we have one more lecture coming up by our very own Dr. MC Patel, sir. It's on legal issues in obstetric injuries. Dr. MC Patel, sir, is the past VP. Of course, we all know that. He is a medical legal counselor. He has a very important role in forming the uniform consents that we all refer to nowadays for our practice. He has been the chairperson of the Ethics and Medical Legal Committee. He has been the organizing secretary of AICOG 2017, as well as the honorary secretary of the SOGOG between 2022 and 2025, with many other accolades to his credit. Welcome again, sir. We have 3 chairpersons with us. Our first chairperson for the session is Dr. Indu Singh, ma'am. Dr. Indu Singh, ma'am, is the secretary of the Bulandshahr Obs-Gynae Society and a consultant at Ayushman Hospital at Bulandshahr. Welcome, ma'am. Our next chairperson is Dr. Anita Nath, ma'am. Dr. Anita Nath, ma'am, is the secretary of the Bareilly Obs-Gynae Society. She is a director of the Nath Hospital at Bareilly. She also is the member of the Oncology Committee and the UP chapter of Obstetrics and Gynecologist and vice president of the Brahmadevi Balika Inter College at Bareilly. Welcome, ma'am. And we have
Thank
Dr.
you so
Beena
much.
Singh,
Thank you.
ma'am, with us. Dr. Beena Singh, ma'am, is the secretary of the Bijnor Obs-Gynae Society. Ma'am deals with high-risk obstetrics, urogynecology, and various gynecological problems. She has a fellowship in infertility management, ART, sonography, and runs her own IVF center. Welcome, Dr. Beena. So over to you, MC Patel, sir. Looking forward to a great session.
Okay. Let me allow to share my screen. Is it seen full screen?
Yes, sir.
Yes.
Yes, sir.
Yes.
Fine. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all the president and secretary of respective societies who have joined this webinar. And my commitment is still there. Wherever you are, I'll be there, promise to reach the unreached. So I'll be seeking your blessings for the post of President Foxy, election year 2026. And just now, process of nomination is going on. So please do nomination in my favor as far as this post of President Foxy is concerned, because last 5 days are there to go for nomination. 31st is last day, and both president and secretary both will have to do the process, and then only it will be considered nomination done. So coming to the subject, legal issues in obstetric injuries, birth injuries. So if we go with this statistic in USA, 78% gynecologists should at least once in their professional career, 37% gynecologists should on 3 or more occasions, and nearly half of the malpractice claims related to obstetric practice. So it simply means that we obstetricians are in driving seat as far as litigation part is concerned. And malpractice suits and allegations of negligence in obstetric cases, especially related to maternal and fetal birth injury, are rising in India. Previously, it was considered as a common complication, and patients were not so keen to challenge this in a court of law or so. But now, for this obstetric injuries also, we are sued in court of law. And patients with high risk pregnancy are being viewed as a potential courtroom adversaries. So few of the advocates have a habit to contact patient that you have to pay nothing, you simply sign my wakilatnama, I will fight case for you, and whenever we win this case, whatever amount we get, you have to give some amount to me. And due to that also, number of cases are increasing day by day. Let us see few of the cases, real happened cases decided in few of the courts. Delivered baby of 4.5 kg vaginally by forceps, and it ended into brachial palsy. So defense on part of doctor was it was complicated case. Patient refused for consent for cesarean section, and baby was getting asphyxiated. So it was the only way to deliver by forceps delivery. But in this particular case, doctor took inference that she didn't give consent for cesarean section. But inference held by the court was patient was admitted at 6 a.m., delivery started at 4 p.m., and no any investigation or sonography or so was done between this period, and no evidence that consent was refused. So even if patient is not ready to give consent, it is a role of negative consent, and we have to mention in our case paper that patient didn't give consent. And we have to ask patient to sign that very document that we are not willing to give consent for cesarean section. Many a time patient is not ready to give negative consent also. So in this situation, you can have signature of any co-patient, signature of any visitor of your hospital, and he or she can sign the document that before us it was explained to them and they refused to give consent. But in this situation, talk to that person who is going to sign this document that if at all it is needed, then she or he should be there in court to favor our role. So in this situation, we have to take complete address and contact number of that very person who is signing that very document. So in this particular case of baby Ramya, compensation was allowed 1.75 lakhs. So case was decided in favor of patient. So in with this case law cannot be adhered to a standard of practice. It simply means law doesn't teach you medicine, how to deal with any given case. So it is our prerogative how to deal with, and we have to treat any patient as per standard medical norms. And if you have treated any patient as per standard medical norm, if at all some complications happens, complications per se can mean negligence. So if at all complications happens, then also we are saved in court of law if we have practiced as per standard medical norms. Medically, it is known that sonography is not accurate indicator of fetal weight as perceived by common man and court many a times. So in this case of baby Ramya, when it was being decided, then this inference held by the court was there. In any case, can it predict disproportion or difficult delivery by sonography or so? So these were the points discussed during deciding this particular case. And in rural area, many a time facility of sonography may not be there. So one has to go with clinical acumen only. And this case was actually poorly presented in court of law. Otherwise, this case was not to be lost. Let us see one more case. Again, it was case of forceps delivery, and it ended into uterovesical fistula. Defense on part of doctor and hospital was this occurred during process. So in this particular case also, court was of opinion and doctor was held liable for this uterovesical fistula. So what is birth injury? There are many injuries we may encounter during obstetric practice. Obstetric anal sphincter injury, very nicely covered by Dr. Sela. Vulval, vaginal, perineal laceration, tear, hematoma, urethral or bladder injury, VVF, RVF, cervical trauma, uterine rupture, again very nicely covered by Dr. Manju Verma madam. So many a time uterine rupture could be repairable and we can save uterus, but many a times it is not repairable and we have to remove uterus. So in all this situation, we should be in a position to justify our action. It is very important part on part of law. As far as fetal part is concerned, fetal asphyxia or birth asphyxia, iphel hematoma, fracture of skull or long bone, clavicle, or palsy, injury during breech delivery, sharp cut on fetal body at the time of cesarean section, and perinatal death. So these are the common obstetric injuries or birth injury we may have to face in our day-to-day practice. But it is very obvious thing that fetal injuries, especially those leading to permanent liability, are more likely to end up into litigation. So if baby is having any injury which could be lifelong and baby is handicapped that way, then they are the likely cases to be end up into litigation. So which are the areas for litigation in this type of situation? Common allegation: improper diagnosis of fetal distress leading to delayed delivery, improper monitoring of process of labor leading to complicated labor, improper interpretation of CTGs, improper application of instrument for operative delivery, improper conduction of labor causing perineal tears, and improper repair of tears. So in this situation, as far as cesarean section part is concerned, one hand, media cries loudly that cesarean rates are getting increased, and on other hand, litigations are for not doing cesarean section well in time, because many a time there could be inference on part of court also, and if at all any expert is on part of a patient, and if they say that if cesarean section would have been done little earlier, then this complication would have been avoided. So in this situation, our role is very crucial, and we will have to justify our action, whichever action we have taken. So which are the areas for litigation as far as obstetric injuries are concerned? Let us see a few of the situations and common allegations. Delayed in diagnosis, investigation, or treatment. If at all there is a rupture of uterus, and if it is delayed in diagnosis and investigation or treatment, then it becomes a case for litigation or reason for litigation. Misdiagnosis, when diagnosis is missed or investigations are not offered and not treated that very case very properly. Wrong diagnosis, unnecessary investigation, no proper concern, staff not qualified, infrastructure issues, sorry, emergency services not rendered properly, communication failure. Many a time we have to transfer patient to higher center.
এর মধ্যে ফরমালিন ট্যাবলেটও দিয়ে দিয়েছি, কেন কি ধরুন আপনার যদি 20 দিন 22 দিন যায়, আমরা তো প্রত্যেক 8 দিনে করি না।
Can technical staff mute them?
এটা
Delayed in transfer. Many times we have to transfer patient, and if it's delayed, then also it becomes a area for litigation. Any complication related to birth, whether it is vaginal birth, it is instrumental, or it is operative. Morbidity, maternal and fetal. Mortality, maternal and or fetal. Overcharging. Nowadays, this is very common allegation. Tremendous expense against unexpected result. And naturally, when we encounter any obstetric injury and we have to repair it, so naturally charge will be increased. And in this situation, this could be a area for litigation. So in court of law, whenever we are facing all these cases of obstetric injuries, then very common question is asked Was it preventable? And usually we cannot say no. So if it was preventable, then one more important question will come. What did you do to prevent it? So whichever measure we have taken to prevent obstetric injury, we have to document it and we have to show in court of law. And if at all we couldn't prevent, then one more question may be asked, why you couldn't prevent it? So we should justify why we couldn't prevent it. And if we couldn't prevent it, then one more question, did you diagnose that very injury well in time? And very important question, did you manage way in which any prudent doctor would have managed? So if at all obstetric injuries happen, it is a complication. And just I mentioned prior also, complication is not negligence per se. But if you have diagnosed well in time, and if you have managed that injury, way in which any prudent doctor would have managed, then you could be out of problem, because many a time ultimate results are not taken into consideration, but your care, caution, and diligence dealing with the patient in that very given situation are taken into consideration. So naturally prevention is always better, and prevention may not always be possible, but we should be in a position to justify our action. So it is suggested by one of our senior colleagues, during cesarean section, proper care not to injure presenting part of baby to avoid litigation. So use 2 Ellis forceps on lower segment and cutting in between and splitting remaining fibers with artery forceps. So it may avoid injury to fetus. So every complication of obstetric injuries are potential threat as far as litigations are concerned. So look like avoiding medical legal problems in our practice is a difficult balancing act. No, not at all. Then what to do and how to prevent? So court and law expect from us only 3 things. Practice foreseeability, that is anticipation, good communication and proper consent, and proper documentation, and you will be simply sail through. So as far as anticipation is concerned or foreseeability is concerned, what expect from us to anticipate that very complication, and we should be readily available with dealing with that very procedure or that very complication with intensive care. So if we can anticipate and if we are readily available to deal with that very situation, then we are out of problem. Say for example, if we are going to deliver a very big baby vaginally, naturally we should anticipate that it may end up into injury, and we should be readily available to deal with situation. And in all this situation, proper counseling is very much must, because if we have communicated them properly, if we have counseled them properly, they are mentally prepared to face this type of complication if at all it happens. And whatever we explain them, it should be in a very simple language. So avoid medical jargon and no rosy picture about result, no tall claim about result, because in our obstetric practice, we consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture, because in obstetric, in court it is very clear, when you claim to be master, you are supposed to be master. Post-delivery counseling is also very important part of our counseling. About what? About injuries. If at all we have encountered any injuries, then we have to explain everything to the patient, what happened and what we have done and what is the probable outcome of this particular injury which we have repaired, and what could be the future treatment plan as far as medicine part is concerned, exercise part is concerned, or physiotherapy is concerned. So we have to counsel them post delivery in a detail, and we have to explain about outcome of that very injury which we have repaired to the patient and patient party. So proper communication and naturally proper documentation is always at our rescue. In this very famous case of C. Jaypal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your communication, of your counseling. So whatever you have counsel, whatever you have communicate to the patient, it should be well recorded in that very consent paper. And once patient and patient party signs the document, it becomes a documentation of your communication. Consent is nothing but documentation of your communication. Whatever you have communicated, whatever you have counseled, each and every point should be mentioned in consent paper, and then patient has to sign in. Once patient signs the document, it is presumed by law that whatever written above was well explained to the patient, and after understanding everything, patient has signed the document. And once you offer all those documents in court of law, it becomes a communication of your documentation. So documentation of communication and communication of documentation are very much important. But you have nothing to worry. You have to simply visit Foxy website. Under Foxy Uniform Consent, we have prepared 30 different consent. We three medical legal experts, Dr. Nikhil Datar from Mumbai, Dr. Dilip Walke from Pune, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consent. And in those consent, we have prepared consent for vaginal birth. We have not mentioned normal delivery. We have mentioned vaginal birth. And in that very vaginal birth, we have mentioned the possibility of this kind of injury. And in this situation, if at all injury happens, then how they will be tackled also we have mentioned in that very consent. If at all instrumental delivery is required or operative delivery is required, we have mentioned that also. And as far as cesarean section is concerned, separate consent we have prepared in that very consent. So we have prepared consent in two parts: information about surgery, and in two parts. That is, part one is information about surgery or procedure, name of procedure. Say for example, cesarean section. Meaning, what is the meaning of cesarean section? Indication. So we have mentioned all the indication. If you have any additional indication, you can mention at the end. Description of procedure, how cesarean section is done. Benefit of procedure, what is the benefit of cesarean section? Alternative, if patient is not willing to go for cesarean section, then are other alternative available to the patient? Consequences of refusal of procedure. If patient has refused, then which are the consequences of refusal, and outline substantial risk related to anesthesia, possibility of excessive bleeding and blood accumulation, infection, injury to surrounding structure. Every individual has a different way to cope up. We have mentioned that also. And rare condition like allergic reaction to drug and neonatal morbidity, possible mortality in few of the cases, and outcome of baby need of NICU care. We have mentioned everything in that very consent. And once patient signs the document, it becomes good defense in our favor. Part 2 is undertaking. So whatever we have mentioned in part 1, whatever we have explained in part 1, patient will go with undertaking in part 2. But in this we have mentioned like this, which is mentioned here in red color. I understand that during course of surgery, doctor may find other unanticipated unhealthy condition that may need specific action, procedure, surgery and anesthesia. If doctor feels that it will be beneficial to treat such condition while performing proposed surgery, and if I am not in a mental or physical capacity to give consent, doctor may take necessary decision after discussing with Mr. or Mrs. So-and-so. I authorize above mentioned person to give proxy consent on my behalf. So if at all we have to go beyond the scope of consent given by patient, if patient has given consent like this, you will discuss with that very person whom she has given authority, and if he give consent, then it will be considered in eye of law as good as consent given by patient. Patient may give consent like this also. Here it is mentioned in green color. In order to save life, it may even be necessary to do additional surgery or procedure or prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if need be. So if patient has given consent like this, then no need to discuss with any relative, and you can very well go beyond the scope of consent given by patient. But in all this situation, burden of proof is always on your shoulder to prove that whatever you did, it was in good faith of patient. So you should be in a position to justify your action. And at the end of consent, signature of patient or thumb impression. If it is thumb impression, then it should be attested by a person who knows that very patient and who is major and mentally sound. Two witnesses, one in favor of hospital, one in favor of patient, and signature of doctor should also be there. Because under Indian Contract Act, unless all the party involved sign the document is incomplete. And in our practice, when we accept any patient to treat, it becomes a contract or implied contract between patient and ourselves. We are offering our expert services, patient pays for that, or patient promises to pay for that. And unless we sign that very document, consent paper is incomplete. But records are always at your rescue. So keep them up to date. What was done? Nothing was neglected. Given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. Give proper instruction to the patient at the time of discharge. So discharge card is the very important document of your record about diet and medicine to be taken, about exercise, about follow-up, and references. If at all you have advised her to go for any references, as per if you have repaired some injury and you have some references with surgeon or any other specialty, then it should be mentioned in case paper. Because in this very case, of course, it was not any obstetric injury part, but it was preterm delivery, and baby was admitted in NICU, and in due course baby was discharged. But during course of admission in NICU or at the time of discharge, nobody advised parents to go for opinion from ophthalmologist to rule out retinopathy due to prematurity. And in due course baby went blind, and case was filed, and compensation of 1.8 crore was awarded in favor of patient and relative. But out of those, 1.73 crore was to be paid by Tamil Nadu government because it happened in government hospital of Tamil Nadu, and rest of the amount was to be paid by neonatologists. Here in this case, gynecologists were not made party. So this gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, then they will never be enough. There are so many cases decided in Supreme Court, in High Courts, in our favor. But if we do not know how to represent those cases in our favor, then they won't be useful. And many times we do not know how to represent our case in court of law with standard references from our standard textbook, our journal, or in any other article published in index journal or so. Then we uh, uh, we are helpless in this type of situation. So it is my humble appeal to have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. There is always a way to so to conclude, minimizing birth injury claims, labor room protocols we have to strictly follow. We have to manage our patient as per standard labor ward protocols, adequate supervision and monitoring during antenatal period, during labor and post-operative or post-delivery, communication, counseling and proper consent, proper documentation, record keeping are always at your rescue, multi-speciality approach whenever you are in need. Do not hesitate to ask your professional colleague to be helpful in that very given situation. It shows your consent to take care of your patient. In time reference, if at all patient is to be referred, then it should be well in time. In era of Consumer Protection Act, we cannot practice without indemnity. So you should have proper indemnity cover, audit of your own case, where things went wrong and what could have been done to avoid this. So not to end up into same problem in future, we should have audit of our own case. So in spite of all this professional and occupational hazard, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient. Strictly treat patient as per standard protocol by medical norms. Pray Almighty God before going to sleep and keep my visiting card below your pillow. I will be always there to assist you. With regards, salute to all the societies who have joined, and to conclude with my humble appeal to endorse my candidature for post of President Foxy election year 2026. Thank you very much. Please do not assume. Please ask if any query, any questions, if time and chairpersons permit. Thank you very much.
Thank you so much, Patel sir, MC Patel sir. It was such a practical so many points like negative value of negative consent, and then what common mistake we do, and the value of how to foresee the things, and self-auditing thing, and then especially counseling in a very simple language. And I think we counsel that time recording thing should be there now
Yes, it is also
in
additional
that place.
precaution. Yeah, we can. But I would advise, if at all you are going to record your counseling and consent, because recording is double-edged sword. Many a time, if you miss important points to discuss, then from that very recording, a smart advocate on part of prosecution may point it out that you didn't mention that. So even if you are going to go for video recording of consent, then paper should be there on your table, and you will refer that very paper. So you are not missing any important point to discuss at the time of
Correct,
taking
sir.
video consent.
It was a great, sir, and wish you all the very best, sir, for your president
Thank you.
candidature. And looking forward to
Yes.
celebrate your win at Bareilly, sir.
Oh yes, but it is humble appeal. If from your society, if you are not nominated, then please nominate. Only 5 days are left.
Yes,
And
yes, sir.
president and secretary both will have to nominate. And it's a job of only 2 minutes. You
Yes,
can
sir.
do it.
Sure, sir. Today only we are going to do.
Yes.
The
And if
link
at all,
is our mail, right, sir?
yes, if you need any assistance at the time of doing nomination, you can have a phone call to me. I'll be there to assist you.
It's very easy.
Okay.
It's
Thank you
not.
so much, sir.
We did it yesterday only. We did it.
Alka madam did yesterday only.
Yesterday, no
Very
problem.
simple
Very
procedure.
easy.
Sir, today I'll do, sir. With
Oh,
Dr.
yes, thank
Latika, I'll
you.
do. Sure, sir. Sir, just one request. How can we
Oh,
get this consent paper made by you, especially vaginal birth and cesarean section?
It is available on Foxy website.
Website is there. Yes.
Open Foxy website and under title Foxy Uniform Consent is available. Or you can give me a simple WhatsApp call. I will send you. It is with me also.
Okay.
It's on the website. Uniform consent
I'll
for
text
all.
you, sir.
Yes. And in those 30 different consent we have prepared, one consent is there for normal vaginal birth.
Your PPTs
Thank
are
you so
so
much, sir.
lovely that even the message is followed. Their presentation is really awesome. We've experienced it when you came. So everything was, ingrained in our mind. We see the cat and dogs and all the animals.
Yes.
We correlate, and it's really very entertaining, very enjoying. And
now
though it's a very difficult subject, but very beautifully you've presented.
Alka ji, my visit to Jhansi is already due. Huh?
Yes, of course, of course. As it is midterm, UPCUG is in Jhansi only. Of course, that is November 28, 29. And I invite everyone. I should have done this in the beginning, but I thought that I should not give my request. So now in the end, at least I request everyone to.
I will be coming as a president-elect.
Yes. Yes.
Thank you. Thank you, madam.
We have five presidents from here.
Thank you.
Those who have come to Jhansi and 5 of them have become presidents.
Congratulations in advance.
Good evening, Alka ma'am.
Right,
Good evening.
right, sir.
Pranam, Manju ma'am.
Yes, Nivedita, any comments or should we conclude? Nivedita?
Hi, Dr. Mridula.
Yes. So, should we conclude or any comment from your side? Nivedita?
From my side.
Yes. Or we can conclude.
Yes, sir.
Anyone, any of the coordinators there? No, Dr. Monica, I think still there. But I would like to thank everyone who's been with us for today's webinar, and it's been very informative, right from all the traumas, from the anal tract traumas to the urinary tract traumas, rupture uterus, and finally covering the medical legal aspects of the same. I would like to thank all the esteemed speakers, all the chairpersons for the series, all lovely people who are all very close to my heart, and wishing Dr. MC Patel sir a very, very, very positive response this year, and looking forward to meeting you all again physically at the next conference.
Thank you.
Signing off today. Hi, Dr. Deepika. Deepika, you're muted.
Yes. Yeah. Thank you. Thank you. It was a wonderful webinar, very informative, and lots of learning and practical learning for all of us. Thank you.
Yes.
Thank you, sir. And thank you all
And
our
I would like to
esteemed
thank Corona Remedies for always being with us and keeping things always on track.
Thank you.
Thank you.
Thank you.
So,
Thank you. Good
Shivani,
night, sir.
Corona people, we can conclude.
Thank you, sir. Good night, sir.
Good night.
Good night. Good night, sir. Good night,
Thank you, everybody.
Yeah, namaste, sir.
Good night. Good night. Good night.